introduced in our posters before. And as you can see, her name is Dr. Helena Musau. Dr. Musau is a consultant clinical stroke radiation oncologist. Alongside that, she's also a palliative care specialist and she works in Nairobi. Away from her academic background, she's a leading voice in cancer care policy, and she serves as an adjunct lecturer at the University of Nairobi, and also serves on the international committees for ASCO and ESMO. So it would be interesting for us to know that Dr. Musau is passionate about advancing equitable cancer and palliative care treatment, and we know that palliative care is a very essential part of cancer care. And she's also passionate about research and mentoring the next generation of healthcare professionals. I think that speaks to why today she's speaking to us, because it's part of what she's doing matters, mentoring the next generation of healthcare professionals in all those areas that have been highlighted. So without any further ado, I would like to invite, in a special way, Dr. Musau to share with us the wonderful things that she has for us today. We will request that we'll give her time to present. Kindly listen in keenly. In case you have a question, jot it down. Then at the end of the session, we will pick questions in rounds of 5. I hope that is clear. So we give Dr. Musau her time. She delivers her content. Then at the end of that, we will take questions in rounds of 5. So if you have anything, just jot it down, and then at the appropriate time, Dr. Musau will answer you. I hope that is fine. And once again, welcome. My name is Roslyn Omolo. Welcome, Dr. Musau.
Thank you very much, Roslyn. And thank you, Kehpca, for inviting me this evening to be able to speak about building compassionate palliative care communities and looking at it in the context of universal health coverage. I think many times we are not sure where the community role falls in when it comes to UHC and palliative care. But I think after tonight's talk, we can explore and also come up with ideas on how to be able to ensure that the community is involved, and that we have, because we do know that we already have compassionate communities, and see how they can work with us to be able to advance the agenda of palliative care. So I would like to share my screen. I'm not sure. I am not able to do that. Okay, I think we can share. Please confirm if you can see my screen.
Yes, Doc, your screen is visible.
Excellent. So we can go. I can get started. So that's the outline of what I shall be looking to cover this evening. So compassion is an essential element of high quality healthcare. I think it's just an essential element of being a good human being. It encompasses empathy, it encompasses kindness, understanding, and respect for patients and healthcare providers alike. Many of the times when we are in the healthcare space, we are not taught about compassion. It doesn't sell. We are taught how to get the job done. And whether you have compassion or not is something that's more of less an individual attribute that you may have. But as we continue to advance in healthcare, and as we continue to see complex cases, and also as we continue to promote and advocate for palliative care, then we need to have compassion being part of the care that we give to our patients. Compassionate communities in palliative care, we are looking at grassroots communities. So it's driven by the community, not necessarily always by the healthcare professional. And it supports people who are facing life-threatening illnesses. It supports the community when somebody is dying. It supports the caregivers, and also goes into the bereavement space. So the compassionate palliative care communities, they emphasize solidarity. They emphasize the social connection in the community. They emphasize a shared responsibility, and they complement clinical services with community-based support. So we're looking to get back to where we used to be as communities, We are looking to get back to caring for each other and not being so busy in the life that we're living that we forget to be our neighbor's keeper. So we are using Nyumba Kumi to be able to advance the agenda of palliative care. A compassionate community is a social model for palliative care in neighborhoods, organizations, institutions. So it doesn't just have to be the community where you're living. It could be in the organization where you're working. It could be in the institutions that we serve, to be able to participate for people who are, having a life-threatening illness, but particularly for those who are at the end of life. We've had colleagues who've been sick. How compassionate have we been as healthcare professionals in attending to those colleagues? How compassionate is the institution that we are working in when it comes to looking at health, at a healthcare colleague or at an individual in that institution that is going through a life-threatening challenge? And many times you find that institutions are there to make money, and so they don't consider, compassion as a good attribute to be able to take care of their staff. But we need to be able to inculcate those values in the different institutions that we come about. The concept of a compassionate community was popularized by a socialist, Alan Kelleher, in the mid-2000s, and he's developed compassionate city charters where cities come together using, the health, not just the healthcare space, but also the corporate space, the social space, to be able to take care of individuals in that community that could be suffering from any illnesses. So the care is not just medical, but it could also be social, where you get individuals coming together to keep lonely elderly people company. It could be emotional, and it could also be spiritual. So we have our different life groups, our different chamas that could be coming in as part of the caring and compassionate community. The communities encourage, they facilitate, they support, and they celebrate care for one another during life's most testing moments. So it's like having a group of people rallying behind you, or rallying behind somebody who's going through a challenging moment, especially when it comes to the healthcare. So the key features that we find for compassionate communities is community engagement. And for this, we can be able to look at the local groups that we have, the local schools, workplaces, any faith-based organizations that we can see, and we can be able to collaborate to provide practical and emotional support. When we think of, say, cancer, because that's the condition that we give a lot of palliative care for in this country, it goes back to the old adage of HIV. You're either infected or affected. So with cancer, you either know somebody who has it, or you have somebody within your family who's going through it. And so everybody in the community has an idea of what a life-threatening illness is. Everybody knows the challenges that could be occurring, but do they know how to support? Have we as the healthcare professionals gone down to the community to engage with them, to be able to provide them with practical and emotional support so that they can be able to also assist other community members? We also have a feature of health promotion when we're looking at the compassionate communities, and where we are focusing on building resilience. We are focusing on reducing isolation, particularly for families that don't have a lot of social support. And we're normalizing conversations about death and dying. Many people die alone. Many people are not aware even that they're dying and are not even being able to make their advanced care plans. And so we are able to focus on individuals who are willing to share, because if an individual is not willing to share, or a family is not willing to share what they're going through, you cannot really assist them. So for those that are able and are open enough to share, then we should be able to focus on building that resilience for them. And then the complementary role, the community works alongside the professional palliative care services that are there. So we are extending beyond the hospitals into the homes, not just doing home care, home visits, but looking at the community in which we are doing those home visits and trying to see how it is that we can empower that community to take care of the individual for whom we are doing the home visit for. And then we're able to have inclusivity. So we address diverse needs in palliative care. We're able to look at the frail and aging. I was shocked recently when I found out that you cannot take somebody to nyumba ya wazee if they have an a living relative. If you can prove that they have a living relative, that elderly person cannot go to nyumba ya wazee. Even if all their relatives are, say, in Nairobi working and they're in the village alone, they will not be accepted into an old age people's home. So how does the community come in? How do we, the professionals, come in to be able to provide that frail and aging care for this community member, for dementia, for chronic disability, and more importantly, for grief and bereavement that we see? So what do compassionate communities do? So when we're looking at care and support, we're able to help the community deliver clinical care, because we are healthcare professionals. We can able to support them for social, emotional, and spiritual care for their families and their carers as well. So we are able to guide them through the illness, through any challenges that they may have, whether it be death and dying and acceptance, and also at the point of bereavement. We can do it in the home, we can do it in the medical space, but we can also involve the community in this care and support and try to identify urgent needs that the individual may have, be it meals, preparing meals, bathing, and be able to assist them in navigating the healthcare system to be able to access that. Can work together with the community health promoters to be able to identify individuals that are at risk or in need. So that comes into community development and community partnerships, where we are able to now build on the skills in the community. Our community health promoters are key partners for us in palliative care to be able to reach the community, and we are able to develop those networks and partnerships, and also any other relationships with other stakeholders in the communities. We have many community-based organizations that were working in the HIV space that now do not know how to fit into the healthcare space now that their funding has gone down. We could interest them into palliative care and building compassionate palliative care communities and being able to assist them to raise awareness in the community on palliative care. And then community activation. It won't happen if the community does not have buy-in. They need to be able to understand what palliative care is. They need to be able to understand why it is that we need to take care of each other, why we need to carve out the time and not always be busy or pretend to be busy, and not, because many people are very private, let's be honest, and they don't want everybody knowing their business. But once we activate the community to know that this is a compassionate program, that this is care that is being given by your fellow neighbor, then they would be more likely to accept the palliative care at the community level. And then we need to continue advocating for palliative care in terms of services, improvement of services, in terms of improvement, in terms of allocation of finances for palliative care. We have a lot of that going on in the other spaces, but for palliative care, we are quiet. The community does not rally behind us, and maybe it's because they don't understand why the need for palliative care is so strong, and that they can actually be able to do something about it. So as we activate the community, they can also help us to be able to advocate for more palliative care benefits. Some of the benefits, it strengthens the social bonds and reduces loneliness. So the community does not, an individual in the community does not go through it alone. They know that they can be able to count on their neighbors. They know that they can be able to count on the healthcare professionals in that vicinity to be able to help them navigate this challenging time that they're going through. It's also culturally sensitive. So we're able to tailor the palliative care that we are giving in this community based on the culture that is already there in that community, so that we don't bring any foreign ideas to this community. Not everybody is comfortable talking about death and dying, even when it's already happening. Not everybody is comfortable disclosing that they have a diagnosis of cancer. So we are able to figure out how to work with the communities to be able to still provide compassionate care, but ensure that we maintain and respect their culture and also their wishes. And it reduces the burden on the healthcare system by mobilizing the volunteers and the informal caregivers. As we empower the community, they're able to do some things on their own. They're able to identify a patient who might need to be birth to might need 2-hourly turning, who might need their garden tilled so that they can still have some food at the end of the day and also get a source of income. So the community rallies together to be able to do this. But it requires community buy-in and leadership. You cannot just walk into a community and start saying that this is how we shall do it from now on. We need to figure out how is that community working, who is in that community, who can we work with that can be a champion within the community to be able to rally for palliative care. We never have enough resources for palliative care. We always imagine that palliative care is cheap. And I think it's the model of palliative care that initially came into the country where it was donor funded. But the truth of the matter is that palliative care can be very, very expensive. If you think of the cost of medication, the cost of rehabilitation equipment, the cost of caregiving, it can be quite expensive. And so we need to figure out the funding and the resources that can be given for palliative care. And we need to be able to measure the impact. As complex as it is, we need to be able to show that the outcomes of having a compassionate community palliative care program actually makes sense, that it actually contributes to the economy of the country and reduces the burden on the healthcare system as much as we can. So how are we able to guide change? There are different principles that can guide and facilitate the development of palliative care communities. And many of the times we still go back to the founder who, can't remember his name, but the one who made the compassionate care communities. He gave some principles that we can work with to be able to help us guide the change in the community. So when we integrate community provision of palliative care and end-of-life care into the public health practice and policy, we are able to ensure that this is known by the community. We're able to ensure that they respect differences and the diversity in the community, such that different individuals' experiences can be used as examples, and then use that to be able to identify the needs and the preferences of that community, which could be significant and varying from community to community, to be able to provide holistic palliative care there. Then we draw on the community strengths to create a supportive environment and generate advocacy. So what is it in this particular community that we want to integrate palliative care in? What strengths do they have? Do they already have an existing program? Is their Nyumba Kumi is very active, such that they already have some care for each other? Are we able to reduce the stigma within this community and promote respect for this community? Are we able to identify the champions in this community that we can train them further on palliative care so that the community can embrace and be flexible as they provide solutions that are appropriate for them? Then we need to be able to strengthen community development to the different networks so that we can increase social connectedness. When we are able to figure out who in this community is relevant when it comes to providing palliative care, not just the healthcare professionals, not just the community health promoters. There may be other individuals in the community that could be able to increase the social connectedness. It could be the spiritual space, it could be the chief, the administrative space. Then we need to be able to work with them to develop action plans for that community that we are working in. And then develop individual knowledge and skills, particularly when it comes to end of life, so that people are not left on their own, so that families are not suffering in terms of accessing healthcare, so that the community can rally around the volunteers that come into this community to help them be able to be retained within the community, because we would have invested in them in terms of skills and also in terms of training them in palliative care. And then we also need to reorient our healthcare services to partner with communities. I think with UHC and the community health promoters being the link to the community, We need to be able to provide education and support them so that they can know what non-health services they can be able to do within the community. We need to be able to empower them so that they can identify patients who are at risk that we could be able to offer care to. And we need to also activate, and collaborate with the care so that we integrate it with the nearest level of care. When we're talking about UHC, sometimes we're looking at not just affordability, but we're also looking at the distance there is to a healthcare facility. Not everybody would want to be taken care of at home. Sometimes people need to go to the healthcare facility for one reason or another, and we need to be able to empower the community and the community health promoters, CHPs, to be able to identify those individuals so that we can get to be working from the healthcare space and together with the community to provide this compassionate care. So the community has different parts and everybody has a role to play, and each person can be able to leverage strengths from a different area to be able to provide the compassionate care. So for individuals and local groups, they're often the catalyst for change. It takes just one person to be able to start communicating about an unmet need and being vocal about it. And they design a response that can be needs-based, can be focused on a person or the experience that they've gone through, and be able to utilize local groups so that we can be able to deliver the different palliative care initiatives that we have. And be able to identify ways in which we can have ongoing development in palliative care, looking also at the sustainability in that community. And then we have the community-based organizations. They facilitate the community access. They can be used for activation programs in terms of palliative care, the community. They can be used to support and coordinate care, compassionate care. We can use them also for trainings in palliative care, and they can also offer access to the nearby healthcare facilities or link together with the nearby healthcare facilities. For ourselves in the healthcare, as healthcare and palliative care service providers, we are an integral component of a compassionate community. We could be specialists, we could be generalists in palliative care, but we all have a significant role to play. And we must work in partnership with the communities at the end of the day. We must be able to leverage each other's distinct expertise. And the good thing about the palliative care community is that we are always in communication. You can reach out to somebody, even in a different part of the country, and you can be able to be assisted. And we're able to provide that focused experience in terms of end-of-life care and even bereavement, using the different resources that we have in front of us. For the national governments, we continue to advocate for more finances. We continue to hope that, the community facilitation of the CHPs, because they're already there, they've been identified, they're on payroll, that we need to just work with them to empower them so that we can be able to upskill them when it comes to palliative care training. And then for the other institutions that we don't think too much about, the schools, the media, the businesses, the unions, and especially for, the members in the community that are going through a life-threatening illnesses and have to miss work. The unions need to be empowered to know to advocate for these patients. The different workplaces that we have to be able to offer support and a positive work environment for their employees that are affected by illness or that have been affected by bereavement of a loved one. And then how do we implement this compassionate care communities? So we are able to identify the needs of the individuals. So we need to speak to the communities and the individuals to understand what their needs are when it comes to palliative care, what their needs are when it comes to end-of-life care, what their needs are when it comes to bereavement, and to be able to use different assets and strengths within the communities to be able to support the networks that are there to fill in these gaps when it comes to compassionate palliative care. We need to be able to confirm the purpose and the desired outcomes. What is it that we want to achieve in this compassionate palliative care communities that we are empowering, that we are supporting? The outcomes need to be aligned with community development at the end of the day so that it can be sustainable. So the community needs to know the purpose, and they need to buy into this purpose, and we need to show them the outcomes. As much as it's not easy to measure compassion, but we need to show them the outcomes in different ways, and I'll just go through that shortly. And then we need to design and plan how to go about providing this compassionate care. As much as it's not always done in the community by the healthcare professionals, we need to be able to empower the community health promoters or the community leaders to be able to organize the community so that they know how to be able to access palliative care. And as we implement the community activation, we need to start small. Don't start big, start small, learn from where you've started and build on the successes of where you have overcome. And once you have done that, then you grow the capacity and you grow the network, and you can move to a different community and be able to ensure that we have communicated about palliative care and the compassion that and the benefits of a compassionate community in delivering palliative care. And then we need to be able to understand and improve. Now, if you don't measure your success, you're not able to improve on it. You're not able to know the mistakes that you've made. You're not able to know the changes that you need to make to be able to ensure that it is of benefit to the community that we have. So the community initiatives operate with high levels of volunteers, supports, and many times limited resources. The government tries to support, but it's never enough. And so we don't always have the monitoring and evaluation frameworks that are needed. There's no way we can be able to say that this compassionate care did X, Y, Z. But if we are able to look at who benefits, and we are able to look at the short-term gains and the medium and long-term gains, then maybe we can have an avenue in which we can be able to, or we can have a gauge for which we can be able to show the benefits of palliative care in the community. So for people at the end of life and families and caregivers, in the short term, we should be able to provide them with more information and resources, and they should have more access to palliative care. And in the long term, we'll see increased likelihood of care and dying in places of choosing, whether it be at home or in the hospital setting. We'll see improved cultural responsiveness. We'll see less people abandoned when they're going through a difficult time, reduced social isolation, and the experience of loneliness. And these are things that can be measured. For the families and caregivers, we should be able to see reduced caregiver fatigue and improved bereavement outcomes for them. For the communities, in the short term, we can increase volunteering. We can even have fundraising efforts for different caregiving events and trainings. And we can increase the number of community activities in acknowledging life-threatening illnesses. Everyone just knows about cancer. Not everybody knows about dementia. Not everybody understands what the whole process of end-stage renal failure is about. So we can be able to give information to the community so that they can acknowledge that they are members in their community who require compassionate palliative care. And by doing this, then you have improved increased the capacity of the community to care for people in all phases of their illness. You've increased the awareness of the community, including palliative care and end-of-life care resources. You can increase the community social capital and cohesion, and a community that works together, stays together, and supports each other and moves forward together. We can increase partnerships between communities, service providers, civic institutions, and many other institutions that are there. So when the community feels supported by the industries where they are living, and that is something that creates a positive and a compassionate environment. And then self-sustaining community activities. So as community-based organizations normally do, they always look for ways in which they can support each other. And that is one of the things that could come out of a compassionate community. And then in terms of the broader healthcare system, in terms of aged care, the social care systems, we'd have more advanced care plans in place. People would be able to talk about, what their wishes are. We can have transparent and formalized organizational commitment to community participation and engagement. And this will reduce the palliative care emergency visits that we often see, the unplanned hospital admissions and reduced average length of stays in the hospital, because there's somebody taking care of this patient. There's somebody who's compassionate in the community. The person going through a life-threatening illness or any illness at that point is not just left in the house alone to suffer. And then there's increased staff motivation and morale. When you see that you're working together in the community and you see the benefits and the outcomes, you also take pride in the joy that pride and joy in the work that you're doing. And then you see increased organizational capacity in terms of end-of-life issues or in terms of illness for people in the workplace. And then you find that health, life-threatening illness are embedded in the core business of the social care systems that we have. Now, bringing it back home, we have our palliative care, Kenya Palliative Care Policy 2021-2030, and it's towards attaining the highest standards of palliative care. We go back to the definitions that we know of palliative care. We go back to healthcare being a right, and this is all encompassed in this policy and is part of the tenets of the policy. But the key pillars we're looking at is integration into the existing healthcare system. And that means going back down to the community, that is the level 1 system in the healthcare space, availability of essential medications, and then education. Palliative care. Many of us did not plan palliative care in our undergraduate studies, and if we did, it was not enough, it was not adequate, and neither were we taught about compassion. We were taught to be able to treat. We were taught to be able to take care of somebody who's unwell. If you think about it this way, somebody doing a surgical case, a surgeon going into theater for an hour will bill less than a surgeon who's going to theater for 2 hours. If you think about psychologists, nowadays their sessions are usually in an hour slot. They don't go beyond that hour. They tell you to hold your thoughts, come back again. Next time we shall address whatever it is you're talking about. But when you're looking at palliative care, many times you're sitting with a family and you can't leave until you address every concern that they have, looking at them in a holistic